So
this
we
is
will
your desktop, right?
Yeah, we'll operate the slide from this end.
Okay.
Okay, great. So I think we'll get started. Welcome everyone to the Data to Care Technical Assistance webinar entitled Boots on the Ground, Follow-Up and Outreach of the Not in Care List. This webinar came about based on technical assistance needs that you all helped us identify, and specifically related to implementation steps and lessons learned after a Not in Care list is developed and taken into the field. Today's call is being recorded in case you wish to share a recording of this webinar with your colleagues who are unable to attend today's webinar. So if people wouldn't mind putting their phones on mute until they are speaking, that will help us greatly with the quality of the recording. So my name is Michelle Clark. I'm from JSI, and I first want to briefly introduce our two speakers for today's webinar. We have Chichi Udeagu, who is the Director of Field Services Unit within the New York City Department of Health and Mental Hygiene's Bureau of HIV/AIDS Prevention and Control. Welcome, Chichi. And I believe you may be joined by a few members from your team.
Yes.
Okay. Would you like to briefly introduce their name and role?
So I'll have Sarah Bernstein, who is the Director for Epidemiology and Field Services Program. Dr. Sabhawal, who is a Medical Director here. And Pierre Michel is the Supervisor for our Out of Care program. And Leonard Pickett is a Field Services Manager with our program.
Great. Thank you all, and thank you for joining Chi-Chi. We also have Dr. Julie Dombrowski, who is the Deputy Director for Clinical Services at Seattle and King County Public Health HIV/STD program, as well as an Assistant Professor of Medicine and Infectious Disease at the University of Washington. Together, New York City and Seattle-King County bring over 10 years of experience implementing data to care programs in their health department jurisdictions. We want to extend a hearty gratitude to both of you for taking the time and your willingness to share your experiences unique to your data to care program models and implementation experience. We will have brief introductions in a moment, and then each of our presenters will take 15 minutes to highlight key elements of their data to care field experiences. This will then be followed by about a half an hour of question and answer discussion. So please hold any questions until after both presentations. So we're going to start with brief introductions by the JSI team, then we'll move to the health department and then the CDC team. So again, I'm Michelle Clark, Project Manager, and also working with the Massachusetts Department of Public Health.
Hi, this is Jeremy Holman. I'm the Project Director and also working with Massachusetts.
Hi, this is Jane Day, and I'm one of the team members for the Data to Care team at JSI, and I am working with the Colorado, Maine, and South Carolina health departments.
Hi, all. This is Julie Powers, and I am one of the TA coordinators as well, and I have been working with Florida and Hawaii.
This is Molly Higgins-Biddle. I'm a TA advisor on the project, and I'm working with Virginia.
This is Amy Flynn. I am project support for the Data to Care project.
Great, thank you. So now we're going to turn to the health departments, and we'll go in alphabetical order. So if you could please state your name and your role in the health department as we go through, that would be helpful. So let's start with Colorado Health Department. Anyone from Colorado?
Hi, this is Annie Walsh from Colorado, and I'm waiting for other people more directly involved in this project to join me in the room, but we are here.
Great, thank you. Florida?
Hi, good afternoon. My name is Corinne Stancil. I'm the linkage specialist here with the Florida Department of Health.
Okay, thank you. Hawaii?
Good morning, this is Michelle Wozniak. I work in HIV prevention. I believe there's a few other people from Hawaii on the call. Introduce yourselves.
Hello, this is Alexa Charpentier with the Hawaii Department of Health and Prevention Specialist.
I'm Anne. I'm also with Hawaii as an intervention specialist.
Right. Sorry, who else? Was that Anne?
Yes.
This is Jennifer in Colorado.
Thank you, Jennifer. And Anne, are you there from Hawaii?
Yes, I am.
Okay, great. Anyone else from Hawaii? Okay, we'll move to Maine.
This is Sarah Bly. I'm the HIV and STD Surveillance Coordinator.
Brenda Kendall, the Linkage to Care Coordinator.
Great. Thank you. Massachusetts?
Hi, this is Betsy John. I'm the HIV and Surveillance Director. I believe we have, but we're all in sort of locations.
Yeah, hi, this is Christian Haig with the HIV Surveillance Program in Massachusetts.
Great. Thank you, Christian. And South Carolina?
This is Eric Jalonen. I'm the STD HIV Surveillance Coordinator.
And Virginia?
Hi, this is Beth Leftwich and Jean Cadet. We're both with Prevention Services and Surveillance.
Great. Thank you all. It's great to have such representation across surveillance prevention on the call today. So now we'll just briefly turn it over to the CDC team to introduce themselves and share any comments related to this webinar.
Oh, just one sec. This is Kelly Voorhees from Colorado. Sorry to interrupt.
Okay, great. No, thank you, Kelly. And did anyone else join the call from the health department?
Yes, Lanisha Childs from Virginia.
Great, thank you.
And Tammy Woodson from Virginia.
Okay, thanks, Tammy. Okay, Luke and team, we'll turn it over to you all.
Okay, hi, this is Luke Schaus. I'm a medical officer at the CDC in the Behavioral and Clinical Surveillance Branch. And I'd just like to just say welcome to everybody and thank you to JSI for organizing the call today. And a special thank you to our two presenters and the folks that are with those programs who are sharing their experience with today with some of their colleagues. We really appreciate the time they're taking to share their expertise.
This is Rondette Jones. I'm the technical monitor for the project here at CDC, acting team leader for the prevention and clinical care team. And I just echo Luke's thoughts as well and welcome you all to this call. We're very excited about Data to Care here and so support the work that has happened so far with JSI, and we're looking forward to this webinar and looking forward to hearing even more about the great work that's happening out in the jurisdiction. So thank you all for your time today, and we look forward to this webinar.
Good afternoon. This is Kathleen Gray. I'm a behavioral scientist here at CDC in the Capacity Building Branch in the Prevention and Clinical Care team, and I'm a part of the Data to Care team here at CDC.
Great. Thanks, Luke, Rondette, and Kathleen. So we're now going to move to the presentation part, and we will start with Chi-Chi. So Chi-Chi, we're now going to turn it over to you. Your cover slide is up.
So next slide. Again, I want to acknowledge some of my colleagues that I had mentioned who are with me here today, and I hope everyone will stick around and help answer questions that the jurisdictions may have. I also want to acknowledge the field workers who actually do the boots on the ground work for out of care work and the rest of our support team here at the health department. Next slide. So there are three main parts to this presentation. I'll give you a background about our program and then describe some of the actual work being done and share with you how we are assessing our progress. Next slide. Next. So the Field Services Unit is under the umbrella of Epidemiology and Field Services program, and we have two main components, our Partner Services program and our Out of Care program. Next. So the field services unit was actually established in 2006 to address the issues of identifying exposed partners from providers who diagnose persons with HIV outside of a STD clinic. So our work has been to work with providers and patients to identify partners, notify those partners, and ensure that notified partners are tested for HIV and assisted with linkage to care. So next slide. So around 2008, based on provider requests, that we not only assist them with persons that are newly diagnosed with HIV, also to assist them with persons who are known positives who may have fallen out of care, to re-engage them in care. However, we were operating under partner services framework, which gives us a lot of flexibility, including linking people to care. And that did not really cover in New York State, encouraging people who once were in care and disengaged in care to return to care. So we had to find a way to frame out of care work to fit the partner services framework, which is essentially that individuals who are not retained in continuous care may have a reload and then transmit HIV to others. So in a way, we were ahead of the treatment as prevention mantra that has been touted in the past 3 years or so. Next slide. Good news, however, is early this year, the New York State legislature passed a law that will actually enable us to more boldly pursue re-engagement in care for people who have fallen out of care. So those laws are now the law is now being studied and interpreted so we can receive actual guidance on how to use it for out-of-care work. Next slide. So now, getting started, what I would encourage the jurisdictions to do, policymakers, is really to study the local laws and regulations and make sure that they develop protocols and procedures, how the work will be done, which includes how to select cases, what forms to use, what data elements should be collected, within what time frames should activities be completed, and also at the very beginning to start thinking of how to evaluate the programs, because you don't want to look back and say, oh, I should have collected this data, or I should have asked this question, or I should have done one thing in a certain way. And also this is really going to help focus your staff to spend their time on doing what you believe could help you achieve your objectives. And then you need to think of how to collect the data in a standard fashion. Forms build databases that should be aligned to those protocols that will be established or already established. And you need to think of what tools you need or your staff need to get the job done, such as cell phone. You need to do outreach to providers, work with them to establish partnerships such as giving your program priority appointments when you find the patients. Do you need cars? What training do you need? Who is going to provide the training? and whatever other resources one can identify. Next slide. So once you've established protocols, procedures, forms, databases, you've identified everything you need to actually get the job done, you then need to think about patient selection. Here in New York City, we use our surveillance registry to identify people who we presume to be out of care because there's no CD4 or viral load report for them for 9 months or longer. And we chose 9 months because by the time we finish with all the other steps and preparations, sometimes it's been 1 year. And then we also use social services databases available to us to try to estimate among those who is actually living in New York City. We made this decision to ensure that when we actually look for someone who is presumed to be out of care, that we have high likelihood of finding the person living in New York City and then being able to offer return to care assistance rather than just verifying that someone had moved or died. And we have social services databases that allow us to make these decisions. Next slide. This is our workflows. You select patients, you go out and try to find them. If they could not be found, then we can assign this position that the person could have died, moved, or just unable to locate. And to the left of the slide, look if we find that an individual is living in New York City, then the person is offered assistance with linkage to care. The person can refuse or accept. If the person refuses, we provide information on HIV prevention. We give them resources, how to reach us in the future if they need our assistance, or how to find help themselves online. And if they accept the link to care, we do help them with appointments, and we offer partner services and provide them with HIV prevention, education, and resources for themselves and others. Next. So contacting patients, this is really where it's really important to spend time even before one makes the first phone call or field visit to get to know who this patient is, because thanks to the internet and the electronic medical record, one can really find a lot of information that would help shape the investigation even before you take the first action. Next slide. So some of the things we do here in New York City is that we examine the registry, see everything we can learn about that patient. We look at both New York State and New York City registry. New York State registry information just became available to us in the past few months. And we look at the vital records to see if the person is still alive. It can save a lot of time and resources if one knows that someone is out of care, appears to be out of care because the person had died. Another very good resource we have is we have access to our correctional facility database right from our desktop. So we're able to find out if someone is incarcerated in any of our New York City detention centers. And if we find that someone is in one of those facilities, we also have access and ability to be able to visit with them at the correctional facilities We are also able to, before that visit, to know if they are already known to the medical staff. If not, we can then visit and encourage them to disclose their HIV status so they can receive care. But we never share that information with correctional facility staff. For jurisdictions that do not have, this kind of access, correctional facility information is actually available online for both local, state, and federal levels. It's just that because of the access we are able to get more information than one would online. Online, you probably get information about whether someone has been released or what crime they committed or how much time they served. Other information that we are able to access is just people that are actively receiving social services in New York City. We have something called Worker Connect. We can log in from our desktop, and we are able to know whether someone is in a homeless shelter or if someone is receiving housing assistance or living in a public housing. And also we are able to receive information about household composition and really good information that can assist us and increase the likelihood that we can actually find someone that we are looking for. And of course, the internet is an excellent resource, both free and subscription based internet search engines. And then to initiate contacts, we are really encouraging our staff, and it works, to text. People respond very quickly, and by the time one mails a letter, you probably have sent a few text messages and received responses. Medical record review is a very good option when we don't have very good information to begin with in EHARS, because EHARS usually has information from lab reports and may not have information on someone's contact address or telephone number. Next slide. So we have a really incredibly efficient data support unit, and what they have done is put all the information together for us on what we refer to as HEPWEB. So we are able to log on to one site, and we are able to see some of these things that I have described, whether it's lab reports or provider reports or field services unit database. We are able to, on your left side, list some of the options that we have, and we are able to go into any one of those areas and get information about a patient that we are interested in. Next slide. So again, to prepare, you have to do your checks to see if someone is in a detention facility, for instance. That way, you're not looking for someone who is safely in a correctional facility, or someone who may have moved. Next slide. And this is the Worker Connect I mentioned, where we are able to find information about people that are actively receiving city social services, and we can get a lot of information if they had used their passport or driver's license to apply for social support. We are able to actually see those documents and retrieve the information that we need. Next slide. So when our staff go out to the field, we actually prioritize our preference where to meet patients. Of course, we are concerned about staff safety, and also we want to operate in a very efficient manner for instance, if we are able to get someone to meet us at a facility, you can not only get a FaceTime with that person, you can also immediately link that individual to care. We meet patients at health department clinics. As I mentioned at the start of building, when you're building your program, you have to establish these partnerships, and we have partnerships with our STD clinics, TB clinics, and if those clinics are more convenient to our patients, then that's where we're going to try to meet up with them. And our out-of-care staff, they have official cars assigned to them. So it gives them privacy, the patient's privacy, if they cannot talk in their homes, or if they agree to be taken to an appointment, it makes things more efficient. And of course, we meet with patients wherever they prefer to meet, in a street corner, coffee shop, parks, or at their residence. Next slide. And we are very concerned about staff safety, and we are very proud that all these years we have not had any incidents, and that's because I believe because of careful planning. We encourage staff to report when they go into areas that they did not feel comfortable about, or where they've experience disturbance. That way we keep a list and make sure that staff do not go to those places by themselves. And we encourage people, if they do not feel comfortable for any reason, that they should leave those areas. We have no choice about neighborhoods, but we have to serve everyone regardless of where they live. So what we need to do is to take precaution. And we ask people to always carry the identification and tell patients who they are, and inform supervisors where they are of their plans for the day. Actually, we have staff calling if they have field work, to call to say that they have reached their destination, to actually call in the presence of a patient, to call a supervisor and say, okay, I'm here. At least the individual knows that if something happens, no one knows. Someone knows where they are. And if they are working off hours, we also have someone on call. And we encourage people not to carry things that are of high value. That way they do not feel like they have to fight for, their large sums of money, for instance. Next slide.
Great. And thank you, Chichi. We have about 3 more minutes, just as you're moving through. Thanks.
So when you meet the patient, again, explain who you are, verify patient's identity. If patient refuses to cooperate with the verification, we walk away, because we would not want to disclose information to the wrong person, and explain how we value their privacy, so they can feel free to share the information. Next slide. We not only want to re-engage them in care, but we also will attend to any emergencies that if we see that someone is suicidal, then that will become the priority, to get that person to an emergency room or some counselors. And then the HIV engagement in care will be secondary. Next slide. We refer based on what the patient wants. If patient wants to go to the last facility, or they want to change facilities, or they want us to make the appointment for them, or they want to make the appointment for themselves, then whatever their preference is, that we just enable them do what they need to do. Next slide. And partner services, of course, that's our core work here. So we do extend offer to assist with partner services. Next slide. Again, we'll call them, text them, drive them, and to make sure that they keep their appointments. Next slide. And we follow up with them and the facility to verify that appointment was kept. If appointment was not kept, we repeat some of the steps I described earlier, 1 or 2 more times. Next slide. And then the next slides are just some of our outcomes. We were able to find most of the people we were looking for and engage them, re-engage them in care. Next slide. This is just a cascade of the flow chart. Next slide. And, people said, most of the people said that the reason they were out of care is because they felt well. Next slide. What we learned from our experience is that, patients are receptive of this kind of service, and there is a reason to do it because most of our patients had high viral loads when we found them, so it was a worthwhile effort. Next slide. So this is the last slide for this presentation. Most of the people that we returned to care actually were in care the next year. They had 2 or more appointments the following year. So now we are doing a longer-term assessment of their retention and care. So the people we returned in 2008, for instance, where they retained in care subsequent years. And, what factors contributed to retention and care or dropout. Next slide. And that's it. I have additional slides that can help other jurisdictions think more carefully about the steps in outreaching to patients, especially if they want to invest time and resources with technology and as well as using surveillance data to give feedback to providers and patients.
Great. Thank you so much, Chi-Chi. That was a really great overview, and the slides are also really helpful references. And certainly at the discussion section, hopefully we'll have an opportunity to delve into more specific components of your program. So before we open it up to discussion, we'll turn to Julie Dombrowski from Seattle, King County.
Great. Thank you very much. Just want to make sure you can hear me.
You sound clear, Julie.
Great, thank you. Okay, please go ahead and go to the next slide. All right, I'm going to speak about what I think are the key considerations for any health department who is planning to do data to care activities, and we'll discuss the history of our program, which started in 2009, and our approaches through these steps. Throughout, I want to talk a little bit about theoretical concerns that came up for us as we were discussing them and have come up in other conversations with health departments considering implementing these activities, and contrast those at times with the boots-on-the-ground realities, the intent of this webinar, and what we learned through the process of conducting these activities. So first I want to speak a bit about an issue that Chi-Chi also alluded to, which is how you restrict your patient list. This webinar assumes that you're starting with the list in hand, but I do want to back up at least one step to say that it's very important, and perhaps one of the most challenging activities here is defining who your target population is. In my view, it is a balance between efficiency and the likelihood of your being able to contact people who are on your list with our population-based objectives as a health department. So you heard about how New York has what I believe is a unique resource, or certainly an unusual one, with the social services database, which really excellently poised them to find patients efficiently. Other sites have done things like restricted their list to people obtaining care at individual clinic sites or Ryan White funding or recently diagnosed. And while that will help with the efficiency of your activities, keep in mind that you are, by your very nature of making that decision, restricting the activities to a certain population. Another way of doing this is to really say, let's take all the cases diagnosed in our jurisdiction or out of our jurisdiction and look at people perhaps who've had their last contact with the surveillance system within a certain window. So not just diagnosis, but the last lab report or clinic visit, something that tells us they've been here fairly recently, and then attempt to investigate those cases and relink to care people who are out of care. Next slide, please. So we initially planned to include both, our initial plan with this was to include both in-migrants and out-migrants. For any of you who aren't directly involved in surveillance, this is capturing the idea that people certainly move after HIV diagnosis, and several of the people who are living with HIV in your jurisdiction and are part of your target population weren't diagnosed in the jurisdiction. Surveillance systems with lab reporting are well set up to ascertain in-migration, but it's much more difficult to ascertain who has moved away. We planned to start with cases that had no CD4 or viral load reported in the past year, or cases who had a lab reported in the past year, but at that time had a viral load over 500. When we started this, the guidelines still recommended therapy for CD4 counts under 500, and through discussions with our community providers, we decided to target that group initially. However, when we first ran the list and did some initial investigations, we realized we needed to really focus first our relinkage activities on that second group of people with marginal labs. So they weren't completely out of care, but many of them were sporadically in care or not well engaged in care. And separately, dedicate significant resources to cleaning up our surveillance system. Lab reporting first became mandatory in Washington State in 2006, and now, having done a full evaluation of our data, I would say it took a good 3 or 4 years before we really had complete reporting. We also realized that we needed to spend some time cleaning up the huge backlog of cases that would appear to be out of care based on missing labs, but in fact had moved out of the area. Once that backlog is cleaned up, which again takes a lot of time and effort, your surveillance system is much better poised to permit data-to-care activities. We, again, investigated every case with no labs outside of King County. Certainly in a jurisdiction like New York, that would be nearly impossible or certainly infeasible. And another way to consider doing this in your jurisdiction, if you're faced with mismatch of resources and numbers of cases, is to consider doing a random sample, for instance, of cases with no labs who were who had their last contact with the surveillance system within 2 years, a random sample of those who had their last contact within 3 years, et cetera, and define the time period at which investigation is no longer worth it, essentially once the vast majority of people have moved away. Next slide, please. But we found, again, when we investigated all of those cases with no data, which again for us was a manageable number of about 2,600, is that approximately half of them have moved away. This has been replicated in other areas and with both in the United States and in Africa, looking at lost to clinic patients. And I would say, with clinic-based data as well, is that most of the people, or at least a good proportion of them who look like they're out of care, are actually gone and have transferred care elsewhere. So this is something you need to attend to in thinking about your data-to-care activities. However, that proportion of in-county patients, 38%, is really our target and who we're going for. When we took into account the out-migration, we found that our estimates of non-retention in care went down from 31% to 16%, a more plausible number. Next slide, please. We have turned that data into a prediction tool, which we don't use here, but are interested in partnering with other jurisdictions to essentially decide how to more efficiently use surveillance system to identify the people who are out of care. What we found when we looked at our data, I'm happy to answer further questions about this, with both developing the risk score and internally validating it, is that the only factors that mattered were whether a person was a King County resident at the time of diagnosis and the years since their last contact with the surveillance system. And that for us, the break point, although we had guessed would be around 5 years, was in fact either at 3 years or at 7 years. And we made some judgments, as you can see there, about priority of case investigations. Next slide. So another discussion that we had pretty extensively, both in King County when we were implementing this in 2009, when, just as Chi-Chi mentioned, I would say a lot of data-to-care activities were not standard, and prevention with positives and treatment as prevention was still being discussed actively and debated. How do we involve HIV providers? So I am an HIV provider, and I work with other HIV providers, and I can see both perspectives. On the one hand, from the health department's end, it's important to involve providers and partner with them to get patients back into care, and it may be that the providers know more about what's going on with the case. When we interviewed key opinion leaders in Seattle about this, many of them expressed interest in at least being notified about who among their patients would be contacted so that they had the opportunity to tell us if there were compelling reasons not to contact an individual on that list. On the other hand, the counterpoint to this, which I think is also correct, is doctors don't own their patients, and should doctors really have the right to decline outreach on behalf of their patients? What we have found in the context of doing these activities is that, first of all, providers, we have really needed to contact them and be in contact with them because they have more up-to-date and complete information than surveillance. This is something where New York, I think, has an advantage with their social services system, but we're reliant upon the contact information that is in lab surveillance and other sources I'll go through in a moment we can find, but very much the providers are the best source of that information. Similarly, they can tell us if patients are involved in studies, and that's why they haven't had labs reported, or are on hospice care and don't have a goal of virologic suppression, and that has really made our activities much more efficient than it would have been without first contacting the providers. That said, to make that work, the relinkage workers really need to make friends and be diplomatic with the support staff to not unnecessarily antagonize the providers and repeatedly contact them, but to really group their lists together and contact them about the process. So that is the process we use now. We extract data from surveillance, group it by provider, fax lists the providers. We do allow providers to opt out, again, for individual contact, which is rare, and then we get updated contact information from the provider prior to attempting contact with the case. Next slide, please. The data sources here I will just mention briefly. I will say that we do have a protocol I'd be happy to share with anyone who is interested from our 6-state consortium on our protocol for conducting these investigations. Just as Chi-Chi mentioned, it's very important to think through the sources you use, and this is what we have decided are the sources that we will use. By far, Accurant, a LexisNexis tool, has been the most helpful for us in determining who has moved out of the jurisdiction and getting more up-to-date contact information before contacting providers. Next slide, please. So I just want to talk a bit more about using Accurant, since I have mentioned and we have talked about our use of this system and found other health departments have run into significant challenges with using it. We already had an Accurant account and we're using it regularly. And we do use this for individual case investigation, meaning looking up a person by name or birth date and seeing what address information is in there. Other health departments that I have spoken with have tried things like sending their list and matching it with the Accurant database, which I will just say doesn't work. I think additionally certainly has some confidentiality concerns. And other health departments who've been interested in getting accounts with Accurant have run into significant bureaucratic challenges I'm sure you're all quite familiar with around contracting and the bid process. So I will just note that that's a challenge, but I think it's worth going through and it's worth health departments considering how we can work together to make this more efficient. In my experience, free sites such as Google Spokio aren't helpful because when you get to the point where you're just about to get the information you need, they ask for payment. Next slide. Dispositions, very important to think about, and I realize we're short on time, so I will try and speed this up, but I think this is a mistake we made. Initially, we planned to track our dispositions as in care, out of care, dead, and gone. With that in care disposition, we missed differentiating between cases who were identified as out of care incorrectly and in fact were in care during that surveillance period, but either they didn't have labs reported or they were getting study labs. That is a different problem and requires a different intervention with your labs and your surveillance system from patients who were out of care but then came back into care during the period of the activity. So those patients now, if we get a viral load that's suppressed and is reported before we contact them, we no longer need to contact them, but we track those separately. Next slide, please. We do have, again, a protocol that I would be happy to share with anyone who's interested from our 6-state consortium, where we had a lot of discussion about how best to define and track the outcomes of the case investigation, the care status of the index patient, and the final disposition. So I'll leave that there. Next slide, please. Who does the work? I think we can talk more about this in the question and answer session. I will say in my experience, a lot of times we spend time thinking very carefully and importantly about how the relinkage worker is going to act with and interact with the person living with HIV. This is without a doubt important, and I think it's helpful if the relinkage workers can have diverse communication styles and ideally some close personal experience with HIV as either a peer or near peer. However, equally and perhaps more important is that they have the skills of a good disease intervention specialist, that they can efficiently investigate cases because, again, most of the cases are gone or people who are not actually out of care. We have also worked with contacting other state surveillance systems or CDC, and I'm going to leave the rest of that till the question section. Next slide, please. Another important point is to think about how you will interface with case managers around insurance issues. We were surprised to find that the most commonly reported barrier to care among people out of care was that they didn't have insurance. This was surprising because we are a state that has essentially universal care for people living with HIV and no ADAP waiting list. What we found anecdotally is many of these were people who were insured at the time of their HIV diagnosis. They lost their job, they lost their insurance, they fell out of care, and they didn't know about Ryan White and the payment systems available. Next slide, please. Key point here, even though we're talking about boots on the ground and field work, I think it is key to the efficiency. Of course, this depends on your individual jurisdiction laws and situation, but to the extent that this contact can be managed by phone and text messaging, I think is a much more efficient and, for most patients, acceptable way of interacting. We do try to minimize the extent to which we're going out literally in the field to patients' homes, to clinics, to cafes. Although we do it, I think that needs to be reserved for a small number of cases and should not be the first line in most instances as long as it's allowed by law. Next slide. Data tracking, I am going to just leave this again since I'm out of time. It sounds like Chi-Chi can further describe their great system in New York, but certainly important for you to have at the very least, I think, an Access database or Excel spreadsheet, ideally a longitudinal data care collection system that can track your outcomes. You won't be able to put all of this in EHARs because of restrictions on the quality of data. For instance, how certain are you about that new address or that relocation? And yet, for your ongoing teams, you are going to want to track that somewhere. Next slide, please. Okay, so thank you very much. I just want to acknowledge as well, I didn't put a slide in and should have, our relinkage workers. We have 2 dedicated DIS-trained counselors who work on this activity. Our surveillance team has been really key at integrating our surveillance and outreach activities, as well as my boss and mentor, Dr. Matthew Golden, and several others. We recently also received a grant for capacity building for health departments, and I just want to invite you to consider contacting us in the future about these activities as we go along. Thank you very much.
Great. Thank you so much, Julie, and thank you, Chi-Chi, for really tremendous resources in the slides and a great overview. I think now is the time to open it up to questions, and the questions can be as nitty-gritty and specific, as concrete, or as broad as is out there, because this is the time to draw on the expertise and experience of Julie and Chi-Chi from their experience. So we'll open the phone line. If you could please announce your health department, your name, and when you announce your question, that would be great.
Hey, this is Janet Tapp from South Carolina.
Hey, Janet.
Hey.
Thanks for your question.
My question relates to the training or the skill set that your 2 DIS-trained counselors have. Is their background social work? Are they peers, health educators, DIS, or what?
That's a great question. So one of them is a DIS-trained, also HIV positive gay identified man who's very open about his HIV status and sexual orientation. He has worked with public health for over 20 years, and he frankly is our go-to guy for new initiatives because he is so good at working with different types of people, providers, patients. He himself has a background training in motivational interviewing as well, but is a very efficient DIS. So we started with him. In our second DIS, we realized we really needed more Spanish-speaking capacity, and we wanted a woman because we were finding that there were several women out of care who Mark was just not having a lot of luck interacting with. And Angela, our second counselor, has been more effective. So she is a native Spanish-speaking woman from Peru who previously worked with a community-based organization doing essentially support for women living with HIV.
But they are DIS skill set.
Yes.
Thank you.
So just prior to this activity, she was doing gonorrhea and chlamydia investigations among MSM to encourage HIV testing. So, yes, they both have very traditional DIS training and experience as well.
Thank you.
Great. And Chi-Chi, did you want to add anything to that based on your team?
No, similar skill set, DIS trained and STD, TB, communicable diseases investigation, and many, many years on the job.
Great. Thank you.
Hi, this is Brian Collins from Virginia. Can you guys hear me?
Yeah, we can hear you.
Hi, yeah, I had a question for Chi-Chi. It's sort of a two-part question. You had mentioned in your presentation that you encourage the DIS as a first line of contact to use a text message. I was wondering what rate of success that had with people. You mentioned that it was fast, but I guess I'm just curious what level of response you typically got with a text message, and also given New York City as a sort of in-transit destination, if there was a difference in response from people who still lived in the city versus people who had moved out of state or to elsewhere in the state.
Text messaging has been really effective. People are responding within minutes sometimes, and people who had previously received letters and did not respond to those letters are responding to text messages. And it's good that you mentioned, that people travel through New York City. Text messaging also helps because we can get response from people who said, oh, I was visiting New York City, I'm now in LA, or I'm in Germany on a business trip, I'll be back in a few days or in a couple of weeks, and we'll keep in touch, and I'll see you when I return to the country.
Great, thank you.
Hello, this is Rosemary Nelson from Colorado. I have a question for Chi-Chi. I would like to know what process you use to gain access to the social services data, and whether you've had the support of your community advisory group or any pushback. Thanks.
That's a very good question. Actually, the Worker Connect that I showed in my presentation was an initiative that our former mayor, Bloomberg, actually started because he, as many people know, he's a billionaire, very successful businessman, and he thought that the city was not operating efficiently. One arm of the city has information that the other arm needs, and then the other arm is, spending money and time looking for information that's already there. So it was his idea that we pull all those resources together, and then what we do, individual program, actually submit application, very detailed application, like what elements of data do you need, why do you need the data, how is that beneficial to the patient. For instance, we say that we do not want to disclose someone's HIV status to the wrong person. Therefore, we need to know household composition, for instance. So lawyers vet the applications and then they approve those applications. So Worker Connect has made it really more efficient for us to go to one site from the comfort of our desktop to get all the information. In the past, we used to negotiate with individual agencies. So I could go to HRA or to the homeless system and say, I want this. And then when a new administrator came, that agreement is off the table. So this is something that your agency has to find out how to negotiate, or maybe talk to your politicians to work together and get something that will benefit the entire city as we enjoy in New York City.
Thank you.
Hi, this is Christian from Massachusetts. Can everybody hear me?
Yes.
Yes, we can, Claire. Thanks.
Hi, I just had a question. You had both mentioned the data collection systems that were set up specifically to collect information related to linkage and to returning people to care. Can you describe anything more about the data systems that you set up? Dr. Dombrowski, you mentioned the need to differentiate the in-care category. Things like that we should consider when we're thinking about what data we would collect and also how those data that we collect would connect back to other databases, to EHARs, any information that you pull from the linkage to care data that you collect back into EHARs or other databases?
Great. I'll answer that first. Thank you, and then turn it over to Chi-Chi as well. So we did program a database in software called DatStat, which was substantially expensive, I would say, but worthwhile in order to track these activities and essentially to help the relinkage workers organize their work. So it essentially keeps track when their follow-up is due, who's at what stage of the investigation. Your point about feeding data back into EHARs is a very good one that, to be honest, we are still struggling with and have tried a couple of different things and are hopeful the next thing will work, which is essentially it still requires someone on our surveillance team to essentially do matching between databases to get that information back. We have, and our surveillance coordinator and lead, frankly, wants to look at that, wants to have some say over what gets updated in EHARs. When we worked with the other states in our 6-state consortium, some of which have much lower HIV morbidity than we do, we simply programmed an access database that really just has key elements for the dispositions and the linkage to care. So I think it's helpful to look at what other jurisdictions have used, just as you're saying, to get a sense of how dispositions are done and whether there are questions you hadn't thought of before. So I think for a lower morbidity jurisdiction, the access database has worked just fine and is much, much simpler. Chi-Chi?
Yes, we have, as I mentioned, we have an excellent team here that develop applications for us and build databases for us. So they really build it to what we need. If we have a need to add more variables, take out variables, they are able to do so for us. And in terms of feeding information back to EHARs, the director of our data support unit is able to extract whatever information he needs to feed back to EHARs. All of our, both the partner services out of care unit information data is connected to EHARs by the patient identification number. So he's able to know that this person who is in EHARs and has been served by the out of care program or that received the partner services is actually the same person. So we retain the same unique number across the various databases. But I'm sure it takes a lot of work to get all that done.
Janet Tapp again from South Carolina. Can you let us know how many attempts your DIS staff made or attempted to reach the client, and over what period of time?
This is Julie. I will answer first. We do have a protocol with some flexibility in it, which is that after we have faxed the list to the provider and followed up with the provider's office, again, for anybody who has a provider, for those who don't have a provider, we go right to attempting to contact them directly. We have a protocol of doing 2 calls, a letter, and then a call. We have only recently started doing text messaging because of a lot of permission challenges that we had internally in our own program, and I'm hopeful that will make it more efficient. So after 2 phone calls, a letter, and a call, if we don't get any response, for the most part, we stop the investigation. Differences, the only place where that, if it's somebody who has not linked to care, we do put more effort in and attempt to do a field visit. And certainly there are other cases where we may know something about that patient, where they come up repeatedly on our syphilis list, for example, that we will make some additional efforts to find.
And over what time period? A month, 6 weeks, 2 months, 6 months?
I think it varies a lot. By over what time period do you mean? How long does it take them to do those calls and letters?
Right. Do they do 2 calls in the first week and then follow up with a letter 3 days after that?
Yeah, that's a great question that I don't know the details to. I think that in general it's within about a couple weeks. It's certainly not much longer than that.
Thanks.
And Pierre will speak for New York City.
In terms of New York City, as far as the work that the DIS will do, when they first get the case, they have 3 to 5 days to begin what we call pre-activity, which will be mailing out a letter, sending out a text if there is a phone number available. We try to identify it as much as possible, whether the number is a home number or if it's a cell phone, via the internet search engine such as Phone Validator. The PHAs will then conduct correctional checks, city and state, prior to going out. And in terms of working the case per se, they have the flexibility of doing 3 visits, 1 early morning, 1 midday, and 1 in the afternoon. And if that doesn't work, we also have the access to having to do medical records to get additional information with maybe emergency contacts using other social services. We're also, due to the fact that we have HR connections, we may be able to call a caseworker who may be currently working the case because the person may be receiving social services incentives. 60 days, I think most of our caseworkers have up to 60 days to work. If by then the case is not found, then we will close the case appropriately, whether maybe not located or if the person was located, refusing linkage to care, we will close it in that sense.
Great, thank you.
Hi, I'm Ashley Carter in Virginia, and I was curious as to what the content is of the text message and how you ensure that you've got the right person on the other side before you disclose, kind of who you are and where you're calling or where you're contacting them from. If anyone could talk a little bit about that.
So this is New York City. As Pierre just mentioned, there's actually a website that will validate a mobile number for you, and it will give you general information, the name of the person, the mobile number belongs to the carrier, for instance. And we do that validation just to make sure that that's a mobile number that we can text to, knowing that most landline will not accept text messages, or if you text to a landline, it will actually be turned into like a voiceover that anyone in the house can listen to. And then our text messages are not different from the letter that we mail out. There's no mention of HIV, someone's HIV status. There's no date of birth or social security number. So you have to check in with your legal team, because we checked in with our legal team and they vetted all of our templates, and they said they really didn't care how we contact patients, whether we call them, we visit them, text them, or video call them, as long as we address the same privacy concerns, regardless of how we contact them. So this is something that you need to check in with your legal team and also your information technology team, because we also checked in with our IT team to make sure that the security of our smartphones will be okay for this kind of messaging.
Do you encourage that they then call you back, and then that's when you ascertain, if they've moved out of the area, or is the communication pretty well limited to text message?
Absolutely. The goal of the texting is to make contact with them, and then the text says to them, ask them to call us back, so we can actually call and verify identity and then pursue the rest of the engagement with them. We have had a couple of people who insisted on, texting, and we encourage them to at least call us back so we can talk to them, make sure they are who we are looking for, and then after that, we can resume texting with them when it wouldn't include, asking someone, what is your name, what is your date of birth, and then, take it from there. And if they refuse to call, then we end there.
Julie, do you have anything to add from Seattle-King County's experience?
I don't. No, it's very similar. The text message essentially says, we're trying to reach you. This is Mark trying to reach you. It's very similar to our partner services protocol, and the discussion actually takes place by phone.
This is Eric Jalonen with South Carolina. I was curious some of the steps you took to clean up your list to identify people maybe who moved out of state ahead of time.
Yes, so we essentially had our surveillance team investigate case by case all of the cases, including in-migrants and cases diagnosed in the jurisdiction who had no labs reported in the past year. And start with, as I think I showed in one of those slides, the stage one, essentially looking at our STD records, looking at the electronic medical records they had access to, and looking in Accurate, and determining whether those people had moved away or died, as well as additional death lookups along with our routine death matches. So it really was just a process of onerous case-by-case investigation.
Does
that answer?
Sorry.
That's okay. Did that answer your question?
Yeah, that helped.
And Chi-Chi, did you want to add anything from New York's experience?
No, it's the same, similar. Our data support team, when we are about to select patients, they match the list to various databases, and we end up with a list of people we believe are alive and living in New York City.
Other questions?
This is Beth.
Oh,
and I had
go ahead.
a quick question on, I know New York uses greater than 9 months, no labs, and King County uses 1 year. What did you use to come to those cutoff dates, or was it sort of trial and error and they seem to be the best?
Chi-Chi, you can go ahead. Go first.
Okay, as I mentioned earlier, we use 9 months, knowing that by the time we are done with preparation, we are close to, 1 year. And also in general, at least in the past, our data tells us that vast majority of people out of care have been out of care for 2-3 years. So there are very few people that were out of care less than a year.
And we decided on the 12 months in addition to that marginal lab criteria, essentially to try and find people who had already been out of care for a year. We do account for a 1 or 2 months delay in lab reporting, and that is partly because we wanted to make sure not to catch or to minimize the chances of catching the patients who were, had been suppressed for decades and decades and are only seen once a year by their provider. Certainly that wouldn't be by guidelines, but several of our large providers really do have many patients who they only see or check labs on once a year. So we wanted to minimize the chances of our getting those people in the out-of-care list.
That's very helpful because South Carolina was struggling with that as well.
Hi, this is Michelle from Hawaii. I realized that when you developed your first not-in-care list, it was a rather large list. So my question for both of you is, going forward, how often were you creating not-in-care lists after your initial list was made?
This is New York City. Quarterly we generate a list. And as I mentioned, we work with people who are receiving social services, specifically social services for HIV-diagnosed individuals. So we match that list to EHARs to first verify that they are in EHARs, and then identify among them who have not had a CD4 viral load for 9 months or longer. And we've been doing this since 2008, so we just generate a fresh list on a quarterly basis or as needed.
And this is Julie in King County. We initially just took the big list and worked through that and did quarterly updates of the CD4 and viral load results, so that for anyone who had had an undetectable viral load reported, we didn't attempt to contact them. We then were doing the list every 6 months, and we now have gotten to the point of having sufficiently cleaned out that backlog to do quarterly updates of the out-of-care list. We don't attempt to contact anyone who has declined interaction with us or who had a non-response within a year. In other words, they may come up again, but we won't attempt to contact them again until 1 year later.
Thank you.
Other questions?
Can either of y'all speak a bit more about your relationships with the private providers, especially? Like when you approached them, did they embrace this idea? Were they cool and then came around?
This is
Julie, you want to go first? Okay, go.
Sure. Again, the context here was 2009, and we did a lot of work at that time, honestly, that I'm not sure we would do if we were starting in 2014. We did a lot of work with community and with providers. We contacted people through surveillance randomly to do both quick by-phone interactions and then more in-depth interviews. We had in-depth interviews with key opinion leaders in Seattle, and we had a couple of provider meetings. Providers fell across the spectrum, like they generally do, but an important thing to note is I was initially presenting this to them as a way to promote antiretroviral therapy, and what we heard from the providers at that time, just like I think Chi-Chi mentioned, was they said, you need to just bring people into the office. We need your help, and they saw it as a public health role to find people who were out of care and bring them back in. So they were more supportive of that, but again, they felt at that time pretty strongly like they wanted the option to be able to let us know if there was someone who was severely paranoid or would get very upset by the call, which again, we had a lot of discussion, but has frankly turned out to be very rare, thankfully. So they have embraced it more over time, like everything with providers and public health, name-based reporting, HIV partner services. I think there's a spectrum of providers. It's been a very small number who've been opposed. I would say it's really 2 now, and most have become more supportive over time. And we get providers, I just want to add, so that is a good sign.
For New York City, we did much of our work when we were introducing HIV partner services because that was not available widely through public health prior to 2006 when the field services unit was established. So we had to start with large providers. We were meeting face-to-face with them, and we were, trying to tell them that this will be a good thing for us to work very closely with them to offer partner services to their newly diagnosed patients. So when Out of Care program came along, we've already done much of the introduction, and actually when we were trying to sell partner services to them, they were asking for return to care work. So they value the return to care work that we do because that's also good for them economically because they have patients to bill for services. In New York City, I think is different for us because we do not seek permission of providers to provide public health work such as partner services or linkage to care services. Of course, as Julie mentioned, there are providers that feel like they own the patient, they should be contacted first. And also due to our laws that prohibited us from discussing patients even with their own providers, that was an easy way out for us to tell them that we will be breaking the law if we talk to them about the patients. So we have a standard letter that we present to providers when we experience resistance, telling them that public health is really exempt from HEPA, and we have the authority to review medical records to extract the information that we need to serve the patients. And we do this very nicely. For the most part, it works. And as Julie mentioned, now providers are contacting us and asking their patients to contact us for help.
This is Julie. I want to add one more point because I do think this is an important one and depends a lot on your local context. But if you have large, especially Ryan White funded clinics in your jurisdiction, they are almost certainly doing something to try and find patients out of care and relink them, in large part because they're required to by their funding. Similarly, if you have large AIDS service organizations or CBOs, they may be considering or conducting these activities, and I do think it is worthwhile at least contacting those organizations and attempting to coordinate these activities or get their feedback to the extent possible. Because you can imagine if you're working from the clinic and calling all your patients back and the patients are simultaneously getting calls from the health department, that can be problematic.
Great. So we have time for about 2 more questions. If there are any other questions for Julie and Chi-Chi.
Hi, this is Rondette from CDC. I just had a quick question. Did I understand you all to say that if someone refuses, services that you would check back with them in a year or no?
This is Julie. That's what we said. Yes. So that is the instance in which we contact someone and they say, I'm really not interested in this right now. Many people will just say, I'm not interested, or I don't have time. so we attempt to, again, see if there's anything we can do by phone and talk with them. Those are the people who we will, again, try and attempt to contact in a year. Same thing with people who we get no response from. If somebody tells us to never contact them again or gets very upset, which, again, has, I believe, been 2 people out of 1,640 cases so far, we will actually mark in our data system not to recontact them, but we do let them know that, of course, if there was an STD, we may contact them for other things, but we will take them off of the contact list for this project.
Okay, thank you.
Any other questions? Okay, and Chi-Chi or Julie, are there any final points that you wanted to impart as we close the call?
This is Julie. I guess I would just like to say congratulations to Chi-Chi and her team on all the work they did. I realize we've been speaking in parallel and about our various program issues, but I think it's really impressive what you all have done in New York, and thank you for sharing it.
And thank you. I've been to meetings with Susan, and I've heard about the work Washington is doing. For the rest of the jurisdictions, I think you really need to study your organization and take advantage of what skills and resources is already available, what the different branches in your agencies doing and how they can help. I think that's really important. And also just reach out to the rest of us and so we can all help each other, because someone out of care in New York City this year could be out of care in Washington State elsewhere the following year, and if they hear the same message from the different jurisdictions, maybe at some point they'll have a change of mind. So, call, email, and we can all help each other to really build a stronger nationwide out-of-care program.
Great. Well, thank you very, very much, Chi-Chi and Julie. We are incredibly grateful to have had the opportunity to hear from you and for your presentation of such comprehensive, useful, ground-level information about your data-to-care implementation. And thank you, everyone, for the rich discussion and great questions. To the health departments from the TA project, we will be sending you an online evaluation and really look forward to your feedback. And as we noted, please let your TA specialist know if you're interested in the online recording of the webinar. Just one final point, we have another webinar hosted by David Heel, or presented by David Heel of the Washington State Department of Health, who will talk about the Washington State Department of Health experience developing an integrated health department data system that's been used to support their data-to-care activities. So again, as we close, we really wanted to thank the speakers and thank you all for your participation, and we look forward to our continued work together. Thank you, everyone. Bye-bye.
Thank you. Bye-bye.